Rabio, we're going to jump into a less funny topic, child abuse. But before we do that, I kind of want to see if you have some knowledge before Mies actually presents it. So, Rob, what bones do kids never fracture?
Well, on their own, if they're itty bitty babies, the ribs. Highly unlikely that they're going to break that on their own.
Good. You're working up a kid for child abuse.
Yeah.
What labs are you going to get, if any? That may be a trick question. So if any, what labs would you get?
Yeah, I'll tell you, this was a change in practice for me a couple of years ago, finding out about this, maybe even from this article. Liver enzymes and lipase. What? I thought that was a joke the first time I heard it, but apparently it's a thing.
All right. It is a thing. And just like trauma patients, right? We're going to talk about that in a minute. But child abuse is a very serious problem. We see it a lot of the times in the emergency department. There's over 700,000 cases, so sad, of child abuse a year. And that's all sorts of abuse. We're specifically going to be talking about, we'll get into it, 4 different subcategories of abuse. But as physicians, we are mandated to report any reasonable suspicion for child abuse. And sometimes that's all you have is that clinical gestalt. You may not even have remarkable signs on your exam, but that sort of sniff test, if something seems off to you, you are mandated to report it. Let's also remember that child abuse, we are not alone. This is a multidisciplinary approach with not just us within medicine, but also your law enforcement colleagues, our social workers, and of course, the judicial system. All right, so this article specifically reviewed these 4 types of physical abuse. So abusive head trauma, this used to be called shaken baby syndrome, cutaneous and intraoral findings, which we'll get into, abdominal trauma, which is really important because sometimes that exam is relatively benign, but not missing those occult injuries is really important, and then fractures, which is probably one of the most common things that we do see. So starting with abusive head trauma, this was previously shaken baby syndrome, right? And the really important take home here is that infants, those little guys, just like they do with everything else, can really present non-specifically. And of course, that doesn't help us at all, because what do? They come in and they're sort of starfished on the gurney, or they look a little punky, or maybe they have that brew episode, that apneic event, or a little bit of altered mental status, or some limp tone. Sometimes that's all you're going to get. And your suspicion for that baby having some type of head trauma really needs to be there. Certainly, if you're seeing signs of vomiting or even seizure, poor feeding, and of course, if you're feeling and seeing a cephalohematoma, this should all raise your flags for child abuse here. And then probably the most important thing, and this is what we always teach our med students and residents, right, is that history needs to be consistent with the exam. So if you get a story that a newborn fell 3 feet because mom or dad says, well, he crawled to the edge of the bed, you need to realize that babies can't crawl yet. So their developmental stage needs to sort of correlate with that mechanism of injury. And an inconsistency there should be certainly a key red flag. So if you are suspecting head trauma, you don't just stop at the head. You need to continue your exam head to toe. And starting at the skin, right, the largest organ in our body, we need to look for bruising and abrasions and other signs of trauma. We should be doing an intraoral exam and really specifically looking for that torn frenulum. That's really pathognomonic for child abuse. If you can get an exam looking at the back of their retina, that's important. If you can't and you're suspecting an infant with abusive head trauma, this actually is a case to call in your ophthalmologist to look for those retinal hemorrhages. It is consistent with about 85% of patients who have some type of blunt head trauma. I think this is one of the cases where when we talk about imaging, certainly having a low threshold to get a CT, probably CT is more appropriate in the emergency department setting. MRI is a little bit more complicated, mostly because you'll have that baby out of the ED for too long and may need sedation, but imaging for sure. This is not the time to be sparing your radiation. And then if you suspect head trauma, they should also get a full skeletal survey. It's really important to rule out other fractures. And we're going to talk about this in a minute, but labs, and you mentioned it already, DeClerc, but getting that CMP, so not just the CBC, not just the BMP and coags, but also those liver enzymes and lipase and amylase, just like we do in our trauma patients if we're suspecting abdominal blunt trauma. So it's a nice segue into here. So any child can have abdominal trauma, of course, but certainly toddlers and older kids are most at risk. Why? Well, because they're bigger. It's like easier to kick a bigger kid, which is so terrible, but true. And really, these kids have the highest risk of death from abdominal trauma. And the reason is because it's hard to pick up these hepatic and splenic injuries. They can be occult much of the time. And just like in a motor vehicle accident, if you have blunt trauma to the abdomen, you also need to suspect pancreatic injury, which is why we send the lipase and the amylase, but also those duodenal hollow viscous injuries. Abdominal bruising is uncommon. And so if you see it, certainly it should raise your red flag for it, but don't, rely on further testing based on bruising alone. Oftentimes it's not going to be there. So if we're suspecting any type of potential abdominal trauma, you absolutely need to be sending those liver enzymes and hepatic and pancreatic enzymes, as well as, again, this is not the time to be sparing radiation. A CT with contrast in peds is indicated if you have that elevated LFTs and lipase, or you are showing signs of a surgical belly.
And Rob, the reason those hepatic and pancreatic enzymes are elevated is because
liver or pancreatic injury. Thinking this is trauma. This is what they're like, little adults right now.
Yep. You can fracture your liver and you can just cause a lot of trauma to the pancreas, and it just starts spilling out those enzymes. So that's why that happens.
Exactly. All right. Which cutaneous and intraoral findings should we be looking for? Well, kids get bruises all the time, right? They're running around falling, but kids typically, when they fall, little toddlers and whatnot, they bruise their elbows, they bruise their shins. They should not typically have bruising over the buttocks, over their hands, on their trunk, especially so in any ambulatory children, those are red flag signs. Any bruising in non-ambulatory infants is also a red flag. And then patterned bruises. So if it looks like a belt or a buckle or a ruler, certainly those bruises should be concerning to you. Same way as in burns. So cigar burns, cigarette burns, anything that looks characteristic is a major red flag. And then frenulum tears as well. And interestingly, I used to think that you could sort of age a bruise based on its color, but apparently that's not true. Typically it goes from that purple to sort of greenish to yellow hue. But basically describing it in your chart is really important. And if you can get photographic evidence, that's even better. Okay, fractures. We see a lot of fractures and they don't always correlate with abuse, but these certain scenarios should really raise our red flag. So fractures in any non-ambulatory children, again, major red flag. Rib fractures. You guys talked about this early on, and you're absolutely right. Not just in infants, but even toddlers as well. So lateral and posterior rib fractures are from a big adult shaking them like this and sort of putting their hands around their chest area and pulling back and forth. So rib fracture should always be pathognomonic for abuse, as well as those metaphyseal lesions. So the chip fracture, bucket handle fracture should raise your red flag. We know from trauma teaching as well that fractures to the sternum, to the scapula, to the acromion are all areas that require high impact. So if you're seeing fractures in a kid in those areas, the scapula, sternum, and acromion, that should raise your red flag for sure, for chest trauma as well. And then, like we said before, any fracture inconsistent with the mechanism should always raise your red flag. All right, so who should get skeletal surveys? Basically, in any child under 2 in whom you suspect abuse, and in any child over 2 in whom a fracture is present and you also suspect abuse. So in infants, you could basically use it as a screening tool, but certainly if you see a fracture that looks concerning in an older toddler, it is also an indication to get a skeletal survey. And then a third cause, and I've seen this a couple times, where you're thinking abuse, but actually it ends up being the patient just has a history of osteogenesis imperfecta. That's sort of a diagnosis of exclusion after you've worked them up for abuse first. So what should we be doing here? The 8 steps that this paper reviews in the assessment of a suspected child who's been abused. We should obtain a careful history of alleged circumstances surrounding the injury. You should perform a complete exam, fully disrobed, ideally with someone else in the room with you as your witness, a nurse or someone. Initiate that diagnostic workup based on your findings, clinical condition, and I would add in that line, just based on your suspicion alone, sometimes that's all you've got. Manage any acute medical issues, of course. You're going to notify Child Protective Services as mandated in your state, and then also law enforcement is also mandated by some jurisdictions. I do this with every child I suspect who has child abuse is I hospitalize them. And the reason for that is twofold. One, I make up a reason that this kid needs further imaging or whatnot, but really you're buying us time in order to get all of those other, people involved, the law enforcement and social worker, et cetera. And also to protect that child from going home with their potential perpetrator. Having hospital personnel or your CPS social worker perform an extensive social evaluation is critical here, and considering additional forensic testing and workup is also important. So in summary, we are mandated by law to report any suspicion of child abuse. Red flags certainly include mechanism that's inconsistent with that injury or the child's developmental abilities. Infants, remember, like they do with everything else. They can present very non-specifically, which can be frustrating, but certainly keep it in your differential. Always be concerned about atypical bruises and torn frenulum, rib fractures. Those are pathognomonic for abuse. And then have a low threshold for imaging. We're talking CT, MRI, skeletal survey, whatever's indicated, as well as labs. And again, we've harped on this many times now, but those hepatic and pancreatic enzymes if you're suspecting abdominal trauma. And that is a quick run through of their recommendations for child abuse.